Good morning, everyone. It's good to have you all here. Our previous core meetings are just a quiet little group, and so it's nice to have a crowd, and we welcome you and are glad that you're here. It's good to see familiar faces that are here too, and be able to be with each of you. For this morning, I'd like to talk a little bit about the stability graphs that we have. The stability graphs tell us a lot of information, from what amount of bone to collect around the implant is making, to the no loading zone and how the secondary bone growth is taking place. It helps us to analyze what the best surface of the implant is, what is the primary stability of the bone around the implant, and the most important to the patient, when can I have my tooth? This was the first study that actually described the primary bone loss and secondary bone growth, called changeover from the primary stability to a secondary stability. In this study, they talked about a time when the implant should not be touched because of the weakened state and waiting until it was more stable in the bone growth, and that was what's happening. In this study, they showed the original osteotomy bone that was drilled and the one where the implant was placed into almost entirely dies, all but about 10 to 15% from the surgery. This was termed the primary stability. And if we admit it, that's a lot of harm that we are doing to our patients. After the surgery and waiting within a day or two, the secondary bone or new bone begins to grow, replacing the dying bone. The two graph lines cross at about the week 4-ish, where the implant is at its most critical and weakest point for strength and can actually easily be unscrewed out of the surgical site. This crossing in time was termed the stability dip and was also labeled the no loading zone. Most implant companies were working on a variety of surface treatments to try and increase the secondary bone growth, but not until Straumann did the SLA surface treatment did they determine that it was the best surface treatment to increase secondary bone growth to the implant. This increase of secondary bone growth also made the stability dip less serious and made the implant more stable and the ability to restore the implant sooner than 4 to 6 months. So literally from the first proposed stability curve, companies began trying to identify things that they could do to change the surface of the implant and make it more receptive to bone growth. It was not until Straumann developed a surface treatment that was not just a theory, but actually began increasing the rate of secondary bone growth to just a few weeks that they got the stability dip to lessen. Then all implant companies duplicated that surface treatment, allowing everyone to have a better stability curve on their implants. After the SLA active surface treatment improved the secondary bone growth, we began restoring implants in 2 to 3 months post-surgery. But no one has really ever worked on the primary bone loss and changing the stability curve until Neobiotech and Dr. Ha proposed that it might be possible to improve that primary stability curve. And what would be the result of that change? And this began the theory of anytime loading. Then the development of self-tapping implants came, and that created a loss of 4% more implants than was existing in the previous implants on the market. But companies sold the idea that you would save time in not having to do a tap drill because the implant was not having to be tapped and the thread design would tap the osteotomy itself. But in reality, we caused the primary curve to drop even faster than before or steeper than before. But with the SLA active surface catching up faster with growth, it created a steeper loss that needed the secondary bone growth curve to increase. In my opinion, we sacrificed the improvement that the SLA active surface treatment made for the more rapid compression necrosis that is caused by the self-tapping implants. And we still have a stability dip that creates a zone of no loading rather than the ability to load in the early time frames. Rather than Dr. Ha going to the self-tapping type of implants, he stayed with the tap drill design because he knew that the tap drill and being gentle to the bone in the osteotomy was so important to enable the osteotomy to not have pressure necrosis created. by insertion of the implant with too much compression of the cortical bone, and Dr. Hall proposed that rather than losing more bone to pressure necrosis on the primary stability curve, he actually changed the primary bone loss to very minimal and changed it from 90% bone loss to about 15 to 20% bone loss. This theory was life-changing to dentists who began following him and this theory. As we began practicing his theory, we began noticing that in Colorado and the United States and other areas of the world, his theory was not a theory. It was a reality for us also. Patients can have a crown anytime they and we want to give it to them. Now patients ask me if I'm getting my tooth today, and I say after I place the implant, we will take an impression or scan, and the lab will have a tooth for you in about 2 weeks. Your gums may be a little sore, so I want you to be careful with the gum, but as soon as your gums feel like you can eat anything you would like, and treat it like a normal tooth. So where do we go from here? What can we do to improve on this reality? Is it possible to have less bone loss than approximately 15 to 20%? And what can we do to achieve that? Being even more careful to cause less bone loss other than what is currently having. Being even more gentle to the surgery site and stimulating secondary bone growth to grow faster. Maybe even other things yet to be thought of to the changing the primary bone loss curve and increasing secondary bone growth. These are things that I think we should consider. Yes, this is monumental changes that we've had in this, both the theory, but also we've changed the fact of bone loss to a minimal. By being able to change bone loss at the surgeries that we're doing to minimal, that creates an opportunity that we have to then say, how can we be a little bit better? What can we do more than we currently are? I think this is where we need to look at for the future, is to say, yes, we've already achieved this level. What can we do to take it one step higher and one notch better? What can we do to help with secondary bone growth? And how can we increase that faster? No one's really addressed that since the SLA active surface. There's been attempts, but nothing has really been successful with that. Are there things that we could do that we could push this theory even better and make this stability graft even better than what it is right now? Someday I want to be a super Dr. Hall, but for now, I'm just a super GP. So I would invite you to join the supers and the family of supers and learning to place implants in a new way, and you're going to be taught that in the next 2 days of how we do that, how these core members do that. This is a reality in our world. We would love it to be a reality in your world. Thank you.
Thank you, Dr. Platt. I think that sets the perfect opening of this session's topic. So now it's time for discussions. We have about 10 minutes. So how does everyone feel about Dr. Platt's presentations?
Very, very nice, and so grateful to hear you again. And I think this topic is about your presentation is really punctual. That means we are talking about in a tiny area when we are talking about just in a healed bone, that native bone, for instance, and the studies that you present is a native bone, and then maybe it's a good idea to talk about the contraindications, about the immediate loading, just maybe to begin to work in a exclusion criteria, if we are going to do a study or something. And how do you think, for instance, to place an implant into regenerated bone?
Great question. So yes, when I look at placing an implant, when I have native bone, that means bone that's healed for a year, not bone that I have just extracted a tooth and placed a bone graft, and now 3 or 4 months later I'm coming to place that. Because that new bone is still regenerating, it's still healing a little bit. And so I need a good solid native bone to place an implant in. And once I've done that, then that gives me the ability to look at and to follow the fact that I don't have a stability dip with my placement. Once I've seen that and the gum tissue itself is healed, then that makes it possible that I can then begin offering my patients the option of having the crown or the tooth as soon as they would like to. So first, it is important to separate the difference between native bone or healed bone versus newer bone that is still present and still undergoing the osteoblastic process, the growing process with that. When we have new bone that is still growing, and by that I mean, a few months. I can place an implant in 3 to 4 months after I've done my bone graft, but can I load it immediately with that? I have tried before and it doesn't work. And so that can be a difficulty in doing that. So instead, what I'm saying is that if we have good healed bone, then that bone will be strong enough to be able to support both an immediate, an early, and a conventional loading for that. The grafts themselves show that there is that instability area or the no-load zone. And we've all learned that. We all know that. Being able to change our mindset from that to say, is this a scenario where I could potentially load during the immediate, the early, or the conventional? And knowing that criteria is what I hope that everyone feels and discusses today, to know that and be able to make sure that we aren't acting foolishly. We're not being presumptive in the choices that we make. We're being backed by science and by each other for the placement theories that we have, so that we can be able to be accurate and that we can be predictable in the things that we're going to do.
Yeah, thank you.
I think the most of the studies shows if we get over 40 Newton centimeters in insertion torque, we can do the loading. But most of dentists do not do immediate loading. They want to wait about 3 to 4 months, even though they get over 40 Newton centimeters. And then the question is why? We have to have a good initial stability for waiting for 3 months. So if you get 30 newtons, and then you can do the loading. But nobody believes that. Why? Because we know that we have a implant can have a stability dip, as you show, right? Even though we get a good fixation, but after 1 week, 2 weeks, implant get loose, get weaker, right?
Yes.
So we know that, so we want to wait. But today, we want to overcome this phenomena, right? We want to eliminate and minimize the stability dip. So if we can eliminate the stability dip, and then we get the 40 Newton centimeters, everybody can do loading anytime, right? So that's the main idea.
I think both companies, studies, and graphs have created in all of us a fear. They've told us, we've learned, we've been taught for decades that do not do anything at this point in time. You must do nothing. Don't even breathe on it. Don't eat on it. Don't do anything.
Right.
You leave that alone.
So we
We've
have to
been taught
submerge,
that. Yes.
submerge for 3 months, right?
There's an enormous amount of literature and data that talks about being cautious with that. Well, that's talking about every other implant company in the world. Every other implant company in the world but this one. This one is the one that's saying, do you really have a stability dip or do you not? You may have one in Hungary, but in Colorado, I don't have a stability dip. You may have,
So,
for example.
so
Yes.
if you believe that there's no stability dip, why don't you do immediate loading or early loading?
I do. And actually,
You do.
I
How
do.
about you guys?
And in reality, I have an implant that was immediately loaded in my anterior area. I had an implant that was done that I was missing or tooth that I was missing since my teenage years. So like Dr. Hall, well, different than Dr. Hall. Dr. Hall placed his own implant. I had my son place my own implant for me, so I'm a chicken, I guess.
All right.
But I did have that, and I loaded it immediately. With that, I achieved with that implant, or he achieved, I shouldn't say I, he achieved 40 Newton centimeters It was in native bone. All the criteria was met, and we loaded it immediately and took an impression for that and sent to the lab for my permanent crown. And so not only do I do that with my other patients, we do that with ourselves. And that is something that not only do we propose, but we believe in. So I can say in my mouth, I don't have a stability dip, being here in Turkey.
Okay.
Okay.
I think it's a great concept, and it's being studied very well.
Turn on.
However, what do I have here? Okay, so I think to solidify on that concept, and we have to choose the right tools to tell the globe about it. I'm an oral and maxillofacial surgeon, so the nature of my practice is to place the implant and send it to the restorative dentist. And I always have this roadblock when I tell them, you can immediately load this implant. And I even give the patient, the guarantee, but a lot of dentists and a lot of prosthodontists don't want to load it immediately. So I think what I'm trying to follow up from your thoughts and Dr. Platto's thoughts is we need to come with consensus that are based on information, and we need to break it down into, whatever the literature is there, it's always anterior, posterior, native, regenerated, and we need to do a multi-center studies.
Yes.
And until we can get to a randomized prospective clinical trial that has the right power, the right number of patients, I think that would be globally let's say the weapon that we can export all of what we have been talking about for such a long time. But it's a great concept. I've been using it since 2019. I've been lucky to use it since 2019. A lot of patients have benefited from it, and a lot of dentists have kind of transformed their practices trying to do the immediate loading. But we need to do multi-center. We need to break it down into anterior, posterior versus native, regenerated, versus single, versus multi-unit, versus full arch, versus we can do it. I think the numbers are there.
Okay. Yep. I think I developed the anytime loading concept, but even for me, I don't do the load, the implant anytime. I mean, not every time. Even though I got 40 newtons, I hesitate to load. Why? Because I don't want to get failed, right? So we have to think more when we have to do, when we can do the load anytime. And the definition of the immediate loading, we will load the implant within 1 week after we place implant, right? Is that correct?
Yes.
And why? Why they do limited the immediate loading, the definition of immediate loading? Why not after 1 week? Why not 1 day? But they make a definition of immediate loading is within 1 week, because they know the stability can change after 1 week. So we want to do everything, the prosthetic part, make impression and deliver the prosthetic within 1 week, because nothing changed in 1 week. So after 1 week, the body will do remodeling of the bone, then the implant will get loose. So before that, we want to do everything. So immediate loading is like that, but the early loading is a different story, right? After 1 week. So to the 2 months. So nobody wants to touch to the implant, right?
Fear.
Why? Fears. Because why? Because we don't want to get failed.
Right. We're afraid of failure,
Yeah.
but we're
afraid of
also
failure.
afraid of success.
Right. So we have to overcome when we're talking about anytime loadings. Anytime loading means including immediate loading and early loadings. We want to touch the implants in any time. And 2 weeks, 3 weeks, 4 weeks, any time. But the literature show by the Straman, they focus on the surface to improve the total stability, okay? So from the 3 months, so they want to make it short to 2 months, and 1 month, right? By increasing the improvement of the surface. But our concept is different. So you want to change the bone remodeling. Can we change the bone remodeling process or modeling process so that we can minimize the bone loss of the old bone? And then if we get 40 newtons and the total stability never changed, then you can touch and make impression and do the loading, right?
Yes.
Is that true?
It's
You
true.
understand that, right? So that's the concept of anytime loading. Okay.
Thank you.
Great. Any questions?